This presentation is entitled Equity in Access to Optimal Pediatric Surgical Care in the United States, presented by Dr. Cockrell from Seattle Children's Hospital in Seattle.
Good morning. It is my privilege to present our work entitled Equity in Access to Optimal Pediatric Surgical Care in the United States. The authors have no real or potential conflicts of interest to disclose. Before I begin, I would like to acknowledge that we are currently located on the traditional and unceded lands of the Kumeyaay people. I honor this land, its indigenous people, both past and present, and their belief in the interconnected nature and worth of all beings. Despite policies and practices that systemically erase their histories from this place, they persist. I also acknowledge that much of what we know of this country today, including its culture, economic growth, and development throughout history and across time, would not exist if it were not for the free enslaved labor of Black people. I honor the legacy of the African diaspora and Black life, knowledge, and skills stolen due to violence and systemic oppression. Inequities in healthcare across the United States are well documented, and realizing equity and access to surgical care is imperative to decrease surgical disparities. Access, however, is not simply a measure of geographic proximity to a healthcare facility. Rather, it is a multidimensional construct that comprises a patient's ability to reach safe, high-quality, and affordable care within a timely manner. Access encompasses not only the resources and expertise of a hospital system and its team, but also the ability of that team and system to deliver patient-centered care that embraces cultural, educational, social, and economic factors that influence health and well-being. This study was designed to evaluate access to optimal pediatric surgical care by comparing the demographics of the communities in which pediatric surgical care facilities are located to the demographics of the pediatric populations they serve, as well as by comparing the geographic location of these facilities to the location of children within the United States. Pediatric facilities providing optimal children's surgical care were defined as ACS Children's Surgical Verification Program Level 1 centers. As not all eligible centers have completed the ACS verification process, a proxy analysis was performed using NSQIP-PEDS participating hospitals. Demographic access was assessed by comparing demographic variables of Level 1 centers and NSQIP-PEDS hospitals to neighborhoods of the U.S. pediatric population. Demographic variables of interest included race, ethnicity, language spoken at home, urban versus rural designation, and area deprivation index, or ADI. ADI is a composite variable that includes 17 education, employment, housing quality, and poverty measures derived from U.S. Census data. A lower ADI corresponds with higher levels of socioeconomic advantage. Geographic access was assessed by the percent of the U.S. pediatric population within 2 hours driving distance of a Level 1 center or NSQIP-PEDS participating hospital. At the time of analysis, 33 centers had successfully completed the ACS verification process. These Level 1 centers are represented by the red circles on the map of the United States. 73.8% of Level 1 centers are located in large metropolitan areas denoted by the dark blue on the map. The centralization of Level 1 centers means that only 54% of the U.S. pediatric population is within 2 hours driving distance of one of these hospitals. 85.7% of Level 1 centers are in neighborhoods that are predominantly white, denoted by the light blue. 95.2% of Level 1 centers are in neighborhoods that are predominantly non-Hispanic or Latino, denoted by the purple. Perhaps unsurprisingly, given the racial and ethnic makeup of Level 1 center neighborhoods, the communities surrounding these hospitals are predominantly English-speaking at 92.9%, again denoted by the light blue. Additionally, Level 1 center neighborhoods are characterized by high socioeconomic advantage with an average national percentile ADI of 31.4. Proxy analysis using NSQIP-PEDS hospitals showed that they are similarly located in predominantly white, non-Hispanic or Latino, and English-speaking neighborhoods. In conclusion, centers with many of the resources necessary to deliver optimal pediatric surgical care may be in locations that present geographic, financial, socioeconomic, and cultural barriers to patients. We feel that an equity component should be infused with all in all care delivery and verification processes to improve access to optimal pediatric surgical care for patients with diverse economic, social, educational, and cultural backgrounds. I'd like to acknowledge that this work was made possible by the Surgical Equity Work Group to underscore population health in the Department of Surgery at Seattle Children's Hospital and the University of Washington, as well as the Health Services Research Center and the Department of Surgery and the Pediatric Biostatistics Core at Emory University School of Medicine. Thank you.
It's a really great presentation. Thank you so much. It's very important to acknowledge the inequities that exist in order to figure out any solutions to it. Does your group have any thoughts about potential solutions to this particular problem in the surgical care for pediatric patients?
We are waiting for a few additional data points that will help inform regional trends. Once we have those, we're hoping to be able to present our findings to members of the college and NISQUIT Peds to partner with them to establish ways in which to infuse equity into the verification process as well as into quality monitoring systems. I think on individual hospital levels, there are a myriad of mechanisms that can be used to commit to equity and improving equity in our care delivery. So things like improving social work capabilities, improving translation services and interpreter services in the hospital, having a commitment to increasing diversity in the workforce at all levels, because we know that there have been studies that show that patient outcomes on the basis of patient-provider concordance across racial, ethnic, and linguistic identities, as well as gender, improve patient outcomes. I think also partnering with the community by establishing community advisory groups to better understand members of the community's experience with the healthcare system and to better understand their needs is important as well.
Hi, I'm Erica Newman from the University of Michigan. Congratulations on this work. I also want to thank the program committee for highlighting this in a plenary session. I believe that we bear witness to one of the greatest civil rights violations in our time, and that is the lack of access for Black and brown children in poor communities to the outstanding high-quality care that we provide as pediatric surgeons. And so this work really highlights that. My question is, the index of, there are lots of indexes that we're looking at to understand where children are that require, that would require our services. And I would say none of them that I found incorporate in a holistic way health disparity. And so there is a center at Michigan called the Center for Poverty Solutions. I don't know if you've heard of it, but they've developed an index called the Deep Deprivation Index. And it highlights, in addition to the neighborhood characteristics, the health disparities that exist in the neighborhoods, in addition to the mobility of the community. And so I guess my question is there an opportunity for us to, as a organization, to put this on the onus of the ACS verification process to include some measure of reach to children that would not ordinarily receive care from a center that is ACS verified? Because I worry that we are passive in this space, and lots of these verifications are coming up, including my own children's hospital, and we're not reaching the children that need us most.
Thank you for your thoughtful comments and question. There are a number of different indices that we've started to use to look at health disparities. I'm not familiar with the one that you mentioned. The ones that I'm more familiar with are Area Deprivation Index and the Social Vulnerability Index. But I think it is worth looking to see if the college and NISQUIP can begin incorporating one of those indices Currently, NISQUIT PEDS does not track a measure of social determinants of health.
Thank you so much.